Good evening, everyone. So my case today is a 65-year-old female patient with a body mass index of around 30, with no history of coronary heart disease, no diabetes, no hypertension. She was dyslipidemic on statins and a smoker. She presented with acute typical chest pain 2 hours earlier with a blood pressure of 170, heart rate is 85, and good oxygen saturation on room air, clear chest. Her ECG showed acute inferior myocardial infarction, ST elevation myocardial infarction. And actually, at that time in our center, we should know where is the lesion, where is the obstruction. Either it is RCA occlusion or LCX occlusion. In this case, this was an RCA occlusion by the ECG, ST elevation more in lead 3 than lead 2, and reciprocal ST depression lead 1 and AVL. So we started the primary PCI by taking pictures of the left system, which was patent, normal with retrograde flow in the distal RC, as you can see here. Then we have seen this tight thrombotic lesion in almost the mid of the RCA. So at this time, we decided for direct stenting of the lesion using a drug-eluting stent, likely 3/23. Then suddenly the patient developed severe chest pain on table, and the blood pressure went down to 70/40. And what happened is, with this injection, we have seen this dissection starting from the ostium of the right coronary artery to the inlet of the deployed stent, as well as the ascending aorta.
Can you show them the point of
So we can see here the dissection and affection of the ascending aorta. So what to do now? Will we stent the ostium, or call the surgeon, or inject the aorta, or do nothing? Actually, in this stage, we should stop injecting inside the coronaries and start injecting the aorta. So in order to know the classification of this dissection, or coronary cusp aortic involvement dissection, either it is class 1 with ipsilateral cusp only, or it is class 2 with extending less than 4 centimeter in the ascending aorta, or it is class 3 extending more than or equal 4 centimeter up the aorta. So we exchanged catheters to a big tail and injecting the ascending aorta. It showed like a small dissection in the ascending aorta. It was very small, so we re-engaged the right coronary artery again, and it was less than around 1 centimeter, less than 4 centimeter, with a dissection extending into the right coronary artery till the stent. So next step, should we stent the ostium or call the surgeon, do nothing? According to the Dunning classification, we should stent the right coronary artery, the whole dissection till the ostium, and even we started with this long stent to cover the dissection till with overlapping to the original stent deployed at the start. And then another stent was deployed till the ostium of the right coronary artery, protruding around 2 millimeters in the ascending aorta. Then post-dilatation to ensure the good apposition. Then the final injection showing patent right coronary artery, TIM3 flow, good myocardial blush, and very, very limited dissection in the ascending aorta. At this time, actually, there was no IVUS available at the site, so we should do IVUS to make sure. So what steps to do in these cases? Stop injecting, this is the first thing to do. Then inject the aorta to know the classification of your dissection. Then decide either conservative management or stent of the ostium, or surgery. That was that one suggested for class 3 dissections more than 4 centimeters. And then you can decide whether to reverse the anticoagulation or do pericarditis if there is any tamponade. What are the possible causes of this complication? The first and most common one is forcible injection, especially when pressure is dampening. The second common one is aggressive guiding, such as Amplat's left guiding catheter, deep engagement, pre-dilatation, balloon rupture, and also CTO attempts. So my take-home messages in this case: recognize early this rare complication in your cases. Stop injecting. The first thing to do is stop injecting in the coronary, and then either, according to the classification, stent the ostium, conserve, or consider surgery. And thank you.